So good afternoon. Thanks for that really kind introduction, Bill. I appreciate it. But we're all here because we're all laboring in that mind still, I think, trying to fix some of these problems. And this didn't surprise anybody here. There's lots of good reasons to worry about healthcare data interoperability. As a payer, though, and I'm going to take a little bit of the payer story here. I'll come back to that. Cost reduction and efficiency are king, right? Because at the end of the day, with a few exceptions of plans, most plans are companies that have a revenue goal and a cost goal, and that's where they're going to get motivated. And we may not like that, but that's the world. They care about improving care, and they care about innovation. But if you don't get past the middle one, you don't get anywhere. But part of the reason, as Bill talked about, I've been passionate about this for a long time, and part of the reason for this goes back, and this was actually in December of 1995. And I remember it was a Wednesday afternoon, middle of the day, I'm a primary care general internist, was walking in to see my next patient. And it was Amelia Thomas, who's a young lady this is all GPT-generated image and fake data, fake names, but Amelia Thomas is about a 24-year-old woman who I'd been taking care of for about a decade. And she was one of those fortunate sickle cell patients that had made a life for herself. She'd done okay. She was about midway through a pregnancy and, in a great relationship and, very excited. One of the happiest people, which is unusual for a sickle cell patient a lot of times, especially in a healthcare setting. One of the happiest patients I know. I'm getting ready to go in and see her. I think this will perk up my day. And at the time, 1995, we were connected to a number of the health systems in Indianapolis, Community, St. Francis, Methodist, and IU Health. And we got these nice summaries printed out because we're still very much, while we had an EHR, paper was still the vehicle when we were interacting with a person. That's what we had in the room, and we called them a clinical abstract. And I glanced at the clinical abstract to see, I hadn't seen her in 3 months, what had been going on. 2 weeks before, she'd been hospitalized, had nearly lost her pregnancy at a hospital across town. And the thing that for me was compelling is walking into that room instead of going, "So Amelia, how's things going?" It was, "Amelia, are you doing okay? How, are things okay? But have you made it through the last 2 weeks? What can we do to make it better?" But that, to me, is what gets me going. And it's that kind of patient level. Where do we make a difference? How do we understand the context that they're living in that really gets me excited and keeps me moving along? A little bit I have to get used to the lag here. As Bill said, I kind of can't find a job, right? So I've moved around. I spent 30 years as a primary care general internist, worked in Indiana to help start, along with Mickey Tripathi likes to say he was the initial CEO of Indiana Health Information Exchange, which is true. But he was a BCG consultant who was there for a few months before we started up. And so I helped start the Indiana Health Information Exchange. I've done a number of things in that space in the national policy area. I've been on committees and whatever. But one of the fun things over the last 15 years is I've spent time on the EHR vendor side of the world and more recently on the payer side of the world. Although as of 2 weeks ago, I'm no longer with Elevance, so I get to say fun stuff, whatever I want. But it has been really great seeing all these different dimensions of our healthcare enterprise and beginning to understand how does this fit together. And so I'm going to try to talk a little bit about that. So Elevance Health, many of you probably know, but it's a large payer, has Medicare, Medicaid, commercial plans in about 30 states. I find it staggering, though, that there's some stats here on number of states and number of people and so on. But what I find even more compelling is that 98% of physicians in the country see an Elevance patient each year, and 100% of hospitals admit an Elevance patient each year. Even in those states like North Dakota, where we don't have plans, we have national account membership, things like that mean that we have connections, relationships to almost every provider in the country, which is kind of cool, but also kind of scary. And in our sort of journey for healthcare interoperability, and that slide and this slide are public Elevance slides. I want to be careful not to steal any internal stuff. but is we have a platform called Health OS, which is sort of our internal interoperability platform. So it connects to health information exchanges, to vendor platforms for interoperability, directly to EHRs at some vendors, or at some health systems and so on. Whoops, yeah. And it's working. So there's data for about, out of the roughly 48 million people, about 28 million of those folks have their primary care physician clinical data flowing on a not real time, but sort of 24-hour basis. Not all bad, but it's a real patchwork, to be honest. But even with that, you know, some not bad outcomes. There was talk just before about quality measures, 12% improvement across a number of HEDIS measures as a result of this data. Now, I will point out, and this is a little bit of a foul, you know, one of those like dirty little secrets, that doesn't mean the patients got better care. It means we got better data in most cases, right? Oftentimes that patient had gotten that mammogram, we just didn't know about it for some reason. And now the clinical data brings that in, or maybe they're, you know, whatever it is. So it's a little bit of a, but still, positive directions. 15% of patients saw their primary care, 15% more patients saw their primary care provider within the 72-hour window after a hospital discharge that we shoot for. 25% increase in medication adherence and so on. So it just confirms what you all know, which is that having good, usable data improves patient outcomes. So when you think about, well, what's a payer need in terms of interoperability? Well, the first is obviously data. You know, connectivity data, I talked about Health OS, but it's more than data. And I think this is, if nothing else, you know, I want the folks in this room to be thinking about this. Having great data only gets you so far. It's what you do with it. And that's true outside, inside, anywhere else. So within Elevance Health, there are many, I think there's 39 or something categorized, uses for this clinical data. And frankly, we are crummy at most of them. So even when we have the data, it may not be fully leveraged for a whole variety of reasons. We may have the data, but not understand that we have the data. Things like that. So there are some real issues, I think, for Elevance Health, and I suspect for other payers, in terms of the usability, not the usability in the sense of what the data is coming in, but is it coded right? Is it coded in a standard way? Is it interpreted fully? So, you know, one of the common examples I like to use inside Elevance is people think, well, there's an ICD-10 code for type 2 diabetes. Person must have diabetes, and if they don't have one, they don't. Well, everybody in this room knows that that's a terrible definition of who has diabetes. And if you naively look at a patient population using that as your definition, you're gonna get some wacky answers. And so having that data in a consumable way is critically important. And then, of course, the other thing that's really important for many health plans, Elevance for sure, is this transition to value-based care. And this has been a journey that, while it's been excruciatingly slow, is progressing. Now, just to give you a sense, the metrics, the scale of improvement in terms of the percentage of people in value-based care that Elevance shoots for is 2 or 3% more per year. So if your baseline is 40%, it's a long time till you get to that 60, 70, 80% that we all know we'd like to be at. But hopefully that will accelerate. But the data are critical to that value-based care model. The last thing that I want to point out, and this varies obviously by health plan, but certainly any national or regional health plan struggles with this, is complexity. And what I mean by that is there are a number of things. First is that the regulations, the models, the data sources are so incredibly variable across the country and even across health systems that it creates a lot of complexity to manage. A good example of this are immunization information systems, which have made tremendous advances over the last decades. And yet you have to be really careful about, well, the data from immunization information system in state A can be used for care management, but it can't be used for quality measurement. And in state B, it can be used for quality measurement and for research, but not for care management. And having to manage all of those complexities and that variability, if at the scale, certainly of Elevance Health, really creates a lot of challenges. So a couple of things, I'm going to spend most of my time here, I think, on this. First is we're all excited about query-based exchange. It scares the bejeebas out of me. And the reason it scares the bejeebas out of me is scale. So it works great for use cases that are event-driven, right? I'm going to go see my primary care provider, and I'm going to, as a primary care doc, I'm going to see my 18 patients a day, maybe, 10, whatever it is, depending on the arrangement you have. Cool, no problem. 10 queries for me, no big deal. Think for a minute about the scale of a health plan doing population health. And the example I like to use, and some of you in the room have suffered through this example before, but just to query the California Immunization Registry for the Elevance population in California, not even the surrounding Nevada and Washington, other states' population that are nearby. Query them one time per month. So a data latency of 30 days we're going to accept. We have to query the registry every 52 milliseconds. And it's essentially a denial of service attack if we're trying to do anything faster than a month. And a month is an awfully long time in the immunization world. And when we were in the midst of the COVID pandemic and trying to facilitate the members who wanted to get immunized being able to get immunized, it was critical to know who wasn't immunized and who was. And we had month-long time lags. Well, a lot happened in a month. And a lot happens in a month at the end of the year when people are getting their influenza vaccinations. And a lot happens in a month when you're in the middle of a cancer diagnosis. So query-based models are challenging for population health type use cases, which are the bulk of what payers deal with. Now, there are certainly event-driven use cases, utilization management being a good example. Right, and I know we were talking about prior auth and utilization management a moment ago, but okay, will you pay for this patient to be on ECMO? Great. Query-based exchange is a fantastic thing, and we've seen great progress in that, being able to reach out and get data like right now, from the current admission to facilitate the utilization review folks being able to render that decision in a very short period of time, which is obviously critical for both the patient and for the health system. But the other thing I would say is that our query-based models and sort of push, publish, subscribe kind of models, we're going to live, I think, in a mixed world for a very long time. I don't see in the next 5 years or 7 years us getting all to a nice Tefka FHIR-based query kind of model. And maybe FHIR version 6, right? We've all got great hope. And, ND-JSON helps. And certainly you can get to scale of hundreds of thousands or maybe even millions of patients in a query, which is what large organizations are going to need to do. Maybe you can get there, but when's FHIR version 6 actually going to be deployed and exist? That 5 to 7 years looks short to me for that to happen. So I think we're going to be, for large organizations, we're going to continue to need to depend on publish, subscribe kind of models for a long time, and organizations that are able to help do that are going to be critical for us as partners. The third thing that I wanted to comment on is the sort of emerging standards and tools. So many of you, we talked earlier in the day about clinical query language, CQL, and I think that's a critical component with FHIR here. And part of the reason I say that is not just the prior authorization issue, although I want to say a little bit about that, but also when you try to make the data meaningful. So inside Elevance Health, we have something we call the Clinical Intelligence Platform. It's built on was originally built on, I should say, some technology from Resolution Health. We run against 120 million patients every day, about 28,000 rules. Those rules are now all in CQL on FHIR. And that was a critical step for us because previously it was this sort of arcane language nobody knew and understood. It was a bunch of, you had to evolve the SQL templates. It was a very difficult kind of platform to scale and maintain. Getting to CQL on FHIR was game-changing in terms of our ability not just to build things and use them, but also to be able to license content from third parties. Been a huge win, and CQA as they migrate to HEDIS measures being in CQL, great step forward. But also, as we talked about before, and I don't think I heard this mentioned much, as we think about prior auth and CQL on FHIR, one of the challenges is that prior auth logic is not written, it's the typical thing of like guidelines, right? There's weasel words in our prior auth language. If the patient's really sick, then you can do this. It's kind of an exaggeration, but not too much. Or they're poor, it's highly underspecified. And so, for example, Elevance Health has a subsidiary which is does prior authorization for Elevance Health and for other health plans. There's, 180 or 190 guidelines that represent several thousand kind of diagnosis procedure pairs, and all it's all laid out. But every one of those, as you work through them, you go, what does that mean? What is the definition of that thing? What is the content? And so I think CQL is sort of underappreciated how critical it is in terms of allowing us to fully specify these things in ways that are, we talked about doing prior auth in seconds. Great goal. But to do that, I've got to have that fully specified logic against FHIR, presumably. And, of course, we're going to have missing data. A great example of that being, has the patient had an adequate trial of physical therapy before getting an MRI for low back pain? Very reasonable thing, right, to ask, has that happened? I would venture, based on our experience and what I know about the practice, that is never in the clinical record fully specified, because that physical therapy took place over here at A1 therapy or something like that. The data is not in the EMR. It doesn't show up in the FHIR. It doesn't show up in the CDA. It's over there. So fortunately for organizations like Elevance, where we can bring the claims and clinical data together, we're able to combine that and look at the claims, because most people like to get paid for those experiences. And we go, golly, yeah, they've had an adequate trial of physical therapy because they had these 8 visits of this type of therapy over a 6-week period. So we're able to say, yeah, that's done. We can auto-approve that MRI, for example. And so that's an example where I think the CQL on FHIR is going to be a game changer, but it's going to require a significant amount of effort for us to sort through how does that play out, how does that work. And I'm going to apologize. The timer up here shows 11 minutes left, and I have no idea where we are. So and it seems to be stuck. So I was just going to ask how much time I have left. Perfect. Good. Thank you. So I do want to say, I'm going to actually go back for just a second here. So, and then of course there's AI, and everybody's excited about the possibilities of, in particular, generative AI. And I think there's definitely applications here. But so for example, in terms of solving data ingestion problems, and I'll talk a little bit more about that. But I think there's definitely a role for leveraging AI, but in a careful fashion. So generative AI, when we think about it anyway, like I said, data ingestion and mapping is one area that we found great application. It helps deal with, especially in CDAs and I'll say it, flat files, which we still receive a huge amount of data as. Helping it with that ingestion and standards. But another really important area, I think, and this is an area where I'm not sure that FHIR or CDAs necessarily solve our problems. So let me give you a specific example. If you look at something like MRIs, right? Especially if the MRI is done by a third-party imaging group, which of course, we like to encourage, right? Because the guy down across the street's half the price of the hospital imaging center. So Northwest Radiology did the imaging. They send the report to the primary care doctor. How does that get into the EHR? It's almost always as a PDF. It's rarely as structured data or even as a text document. And when you query the EHR and ask for the data from some time interval, do you get that PDF? Not very often. But even when you do, it's almost always as unstructured data, right? You might get the PDF, you might get a text version of the report. You don't get structured data from that cardiac cath, that echocardiogram, that MRI. So if you want to do automation, if you want to do summarization, if you want to do some of these other things, I got to take that apart. Now, this is a little bit of a side, but I think one of my pet things is we got to get away from the echocardiogram system did all these measurements. The cardiologist or their technician made interpretations and measurements, and then we turn it into PDF, and then we send it to somebody who takes it apart. That echo system is perfectly capable of sending us the structured data. Inside most health systems, that capability is not being leveraged. So you're getting a text blob or a PDF of that report. So I think for these more sophisticated diagnostic modalities, one of the things that I think we've really got to focus on is how do we get that data in structured form out of those systems into the EHR, into the exchanges, or whatever it might be, so that it can be accessible. But until we do that, generative AI is actually pretty darn good at taking them apart and dealing with some of the really challenging problems of tabular data, for example. Like one of my classic examples is a right heart cath and somebody's got pulmonary or being evaluated for pulmonary arterial hypertension. There's typically a set of measurements with and without provocation with nitrous oxide. Well, there's a column header that says W space NO or something like that. How do you interpret? Well, the Gen AI is actually pretty good at finding those things and sorting it out. And so that's one of the places why it's like a Band-Aid in my view, but it's a helpful Band-Aid at present. And then the other thing, of course, is in that vein of making data useful is summarization. So, and I'm sure that any clinicians that any of you interact with will tell you, I don't want to see 32 screens of data about Mrs. Jones. And so there's been a lot of nice work done, here's the Smart on Fire app that just gets all the stuff relevant to the diagnosis that the person's in the ER for, or that kind of thing, and that's helpful. Or even the Oracle Health, AI EHR, what does it do? Well, if I say I'm focused on diabetes, it'll just pull the diabetes stuff together. Helpful summaries, right? But the notion of being able to distill through those thousands of data points or even hundreds of data points into a useful format for your purpose is really important. And the utilization management example I talked about before, so even in the world where we can go and query that hospital record and get it in a few seconds or minutes, and that utilization review person is now looking at it, they've got 192 pages to look at to answer this question, to find the relevant information. So summarization becomes a really important part of this, and especially as we think about exchanges and things, it's one of those services that I don't think, health system A is not going to build it and health system B. Vendors, EHR vendors may build it, others. But it's a really important kind of a function to make that data useful and adaptable to use cases. But it's also not falling off a log. When we started out almost 2 years ago at Elevance Health using generative AI to summarize for utilization management, it seemed very promising. You'd look at the first 10 of them and you go, that's pretty good. But then you realize, well, it takes a little longer than you'd like. It takes 20 minutes, and we just don't have 20 minutes to do that. It costs $40 for the generative AI model to run. Not to build the model, not to train the model, just to run the darn thing, which is why 3 Mile Island's being reactivated, right? These are really expensive to run. And so over a couple of years, we're able to drive those costs down to about $4 per record, and that was now comparable to what people time to do it would cost. Because you think about $40, I can have somebody spend some time summarizing it. So generative AI has, I think, a number of roles in data interoperability here in terms of cleaning up the data, but more importantly in terms of leveraging the data for use. So when you think about an organization like Elevance, where are we where is that organization focused near term? The first is on data quality. And frankly, to the level of saying, we're not as worried about connecting a lot more folks, but rather making sure that the data for those 28 million people that are there is high quality and usable. And that's a lot harder than you might think. And Ryan did a nice job before talking about some of the data quality issues. It is a real challenge because we don't have a good way to, that's agreed upon and systematically applied to measure it. And it's use case dependent, right? The quality of the data for something like quality measures, okay, we can, maybe come up with a way for that. But now what about risk adjustment? Well, for the quality measure, it doesn't matter about physician signatures and things like that, but for risk adjustment, I've got to be very specific about the physician signature block, and it can't be an aggregated CCDA, it's got to be an individual encounter level CDA and things like that in order to be usable. At least some regulators would interpret it that way. So the quality is not just quality, but quality for what? For which use case? And the flip side of that is you can get overly focused on the quality and say, golly, this isn't high quality. Well, maybe it's not, but it's still, what's there is still useful depending on the use case. So quality is one of the major foci right now for Elevance Health as opposed to more data in particular. The second is, and this just goes back to my theme before, is operational impacts. Making sure that what is there is getting leveraged all of the time. A good example of that is being a far-flung enterprise and in fact separate companies like Payment Integrity, the team that looks at fraud and abuse and things like that, might want a medical record to review to figure out whether something's going on. And that record may even exist in the organization, but it was obtained for the purposes of, say, quality measurement. And so making sure that you really have a way for everybody to leverage the data that exists and to make sure that they're fully leveraging the data that exists becomes really important. And this just gets back to that original point that at the end of the day, it's all about how do you create value out of this. And if you're not fully leveraging it, you're sort of paying more per value than you want. Then talking about prior auth for just a minute. And I think, and we just had a panel about this, but I would say that the regulation is not a big driver right now, at least for Elevance, because it's way in the future. And you all know how long it gets there and how much work that's required, but they don't. And so it's not top of the world. The second thing, though, is, and this goes back to complexity, and I mentioned a moment ago, so there's Carelon MBM, a subsidiary that does prior authorization for a portion of procedures. Other things are prior auth is done within the health plan. Other prior auths for medications are done within Carelon RX, of PBM. Others are farmed out to yet other companies. It's not as simple as the provider requests the health plan does prior authorization. And then complicating it even further, Carelon MBM, the prior auth company that Elevance owns, and Carelon RX, which both serve hundreds of health plans. So they're doing prior auth for many, many health plans. So I think this, we do have a lot of work to do here in terms of sort of routing clearinghouse type challenges with prior authorization, even when you have sort of the glory of having the full kind of Da Vinci model worked out and working. I think there's still a layer of complexity there that we haven't even begun to deal with. And the other side of that, I think, is, and I talk with one of my colleagues at Carolina MBM a lot about this, is we have a lot of opportunities, I think, even to do, I'll call it, poor man's automation. So just as an example, when a request for prior authorization comes in, data is needed. And Carolina MBM is very famous for they've got some algorithm and people go to the web and fill it out and they get can be auto-approved or it goes on to the next stage of human review and so on. But just think if you could take advantage of that point of querying eHealth Exchange and getting all of the data, or much of the data is relevant, could you auto-approve another 15%, 50% of those requests because you had more complete data? Things like that. So I think even without getting to the sort of full-blown Da Vinci wonderful nirvana, which, like I said, still has some things to happen, I think there's some things we could do that would expedite and improve prior authorization even without going quite to that level. So there's all these things are tough, and we've talked about a lot of these things, but cybersecurity risks, obviously, huge issue. Many of you know that Elevance Health when they were as Anthem, had a breach a decade ago that led them to be incredibly tight in their security, which is great and wonderful, but it's a threat. It's something that you worry about every day when you have data for 120 million people in one place. It's a scary thing, right? You're a rich target. Consents are obviously an issue, and the complexity, the variation of states and laws. And one thing that I want to call out there is about the so-called sensitive data, which has turned out to be a real issue. And I can't remember, I was talking to Brian or somebody about this a couple of days ago. What is sensitive data? How do I identify that? Maryland, I know, has done some work. There's some other things, but there's questions about behavioral health data, but also reproductive data, what could go out of the state, things like that have surfaced. And so consent and legal complexities just exacerbate that difficulty, and I think it's one of those areas where there's a lot more to be done. And then lastly is trust, and I mean trust in a couple of ways. There's obviously trust in the data, and for example, we've just recently launched an HL7 work group on payment integrity and trust, because how do you know that FHIR resource is right? Because I can Gen AI a whole bunch of FHIR resources for people and send them to you. Right? How do you know that's real? How do you watermark it? How do you deal with that, for example? And then the other side is, as we become increasingly dependent as a health plan on these clinical data and the flows, what happens when it's dead, even for a short period of time? And so, you think about redundancies and business continuity plans around those things. So my wife has hostess anxiety, right? We always have 3 times as much food. Well, I have presenter's anxiety, so I have like 10 more slides, but I'm out of time, which is okay. It was sort of designed, this is my buffer, right? But the last couple of thoughts I want to leave you with is, one is we have come a long, long way. Right? I mean, just think about, and those of you who haven't been around 20 years or 10 years or 5 years, it may not seem like as much. We have come a very, very long way. And that has created tremendous opportunities, which is really exciting. And I think we're at the cusp of solving some of those things. And so I think the things that we've got to do, though, is we've got to be not just thinking about what we can do in the future when version 6 of FHIR is out and things like that, but what can we do today, and not worrying about, well, we got to have full Da Vinci interoperability, everything working, but what can we do today to make prior authorization better, leveraging the assets and resources and capabilities that are available through eHealth Exchange, through HIEs, through vendor platforms and so on, while at the same time keeping an eye towards where we want to go. But I think if we get too focused on moving the data, making things better, we lose sight of the fact that we're doing that for a reason, and we need to do it now as well as we can and not let, it's the old adage, don't let perfection be the enemy of the good. And I think there's a real risk of that sometimes with, well, we're going to get to fire. Well, we're going to get to, and that's all good and proper, but at the same time, I think we've got opportunity to make a lot of headway given all the work, all the progress that's been made, and get the benefit for those patients, that we're all doing this for, and then make it better along the way. So thanks very much, and I don't know if there's maybe a couple minutes for questions here.
Raise your hand if you have a question. We have one over there.
Hi, Mark. Hussein from the FDA. Just curious, you mentioned the great success and progress that you made with the CQL engines, but at the end you left me with like a cliffhanger. You told me that there's a lot of work and there's a lot of things to be done. Would you be able to elaborate a little bit on some of the challenges that you faced?
Yeah. So several things at a high level, though. The first thing I think is scale. Most CQL engines will not scale to population health levels. And so I think that is an ongoing challenge if you want to do population health level things. And I think there's pathways to that. And in fact, that's one of the things we're very excited about the work that we did at Elevance was being able to get to that scale. But that's not a common capability, I would say. The second thing is I think we have some real challenges with the fire implementation guides. There's still a lot of variability. And it's not so much a challenge with the guides, but the fact that, for example, you can start out with the NCQA quality fire implementation guides for HEDIS measures, but then you run into limitations to do other things. And so you get a different fire implementation guide for that. I think, there's so we ended up at Elevance with multiple fire implementations to handle this different flavors of CQL, if you will, and all for good purposes, right? They're all things that you went, golly, we can get to here, but now we want to do this. And then the last thing I think on that front is that I'll call it administrative data, whether that's claims, but also just as importantly, data from, we call them programs at Elevance, but we hire vendor X to interact with women who are pregnant to get them to do whatever. Well, that's a program. How does that data get represented in fire so that you can be sensitive? So it's these extensions, it's the usual problems, Z segments, whatever. It's those variabilities that still, I think, get us. And that's okay. Again, get the 90% and then work on the rest. But I think those are the two big things, is that variation in the implementation guides that are required for different things that you want to do, and then the scale.
Mark, we have a question over here.
Hi, Mark. I'm Overhage from NCQA. Thanks for the shout out. I want to kind of chime in there that NCQA has created an initiative around CQL standard harmonization or maturation. We call it the Digital Quality Implementers Community. Levitt Partners, I'm sure Ryan is here somewhere, manages that community. That community is aimed at making sure that the CQL engine implementations out there are standardized, unambiguous, and run the same way when it comes to running HEDIS measures in CQL. It's almost like being able to run an equation or execute an equation, mathematical equation, the same way across all the calculators out there. And so we're hoping that this will offer a choice and confidence in the market when it comes to CQL engines out there. So that's the end game for this community.
Thank you.
Any other questions? All right. Well,
Thanks
let's put our
everybody for
hands
letting me join
together
you.
for